I would like to welcome and thank Dr. Elizabeth Donner. And without further ado, I'm going to pass this over to our expert. And thank you again, Dr. Donner, for joining us.
Thank you very much. Thank you for the opportunity to speak to your group today. I understand that the topic of mortality within epilepsy in the prison population could be a concern, and so I'm grateful for this opportunity. So just to start out with a little bit of information on epilepsy. Epilepsy, of course, is the chronic condition characterized by recurrent unprovoked seizures. So any individual who has a seizure more than one time, so 2 or more times, would qualify as having epilepsy. And epilepsy affects about 1% of the population. There's actually, just in a little bit of reading since I was going to be speaking to this group, I recognize that there's a literature describing the historical misconception regarding criminality and epilepsy. So with a kind of an old held belief that in fact people with epilepsy were more likely to be criminals or to commit crimes. And of course that's been shown to be not true more recently. And in fact some of the older studies, and there's 4 studies referenced in the bottom corner of this slide, but the studies from 1969 and 1986 actually demonstrated an increased prevalence of epilepsy within prisons compared to the general population. However, newer studies from 2002 and 2008 have not found that. So Fazell in 2002 conducted a systematic review of survey studies that had looked at the incidence or prevalence of epilepsy within prison populations and demonstrated that there was no increased rate of epilepsy among prison populations compared to the general population. And Pitensor in 2008 performed an audit of a UK prison population and found that although there was increased reports of epilepsy within the time of entry to the prison, when they actually dug down and looked at those reports of epilepsy, and these were reported by the admissions staff, I guess you would call it, at the time that people entered prison, when they actually dug down, they found that some of the epilepsy diagnoses were not accurate, and that when you actually looked at it, the rates of epilepsy within the prison population the same as in the general population. It is well known that people with epilepsy have a 2 to 3 times increased risk of death compared to the general population. So if you look at the life expectancy of people with epilepsy, it's reduced by about 2 years in people with idiopathic epilepsy and up to 10 years in those with symptomatic epilepsy. And I'll define those terms in case people are not aware of them. Idiopathic epilepsy is really just epilepsy alone without any underlying cause other than perhaps a genetic mutation. And people with idiopathic epilepsy tend to have only epilepsy and not some of the other medical comorbidities, in contrast to symptomatic epilepsy, which means epilepsy is a symptom of something. So for example, brain malformations, cerebral palsy, head injury, something like that. And so another interesting point is that the reduction in life expectancy declines over time. So if a person is going to die of their epilepsy, if you look at all the different causes of epilepsy, if a person is going to die who has epilepsy, they're more likely to die earlier in the course of their epilepsy. And that's because most of the deaths associated with epilepsy are due to the causes of symptomatic epilepsy. So for example, an acquired brain injury or a brain tumor or cerebral palsy. In general, the risk factors for premature death in epilepsy, and this I already mentioned, the first is the underlying condition or symptomatic epilepsy. Another strong risk factor is having what people call active epilepsy, and that's defined as the absence of 5-year remission of seizures. So having had seizures within the last 5 years is a risk factor for mortality. Difficulties with drug adherence, and AED stands for antiepileptic drug. That term is synonymous with anticonvulsants, so it's just medications for seizures. Difficulties with adhering to drug treatment for epilepsy is a risk factor for mortality. And another strong risk factor is medical intractability, or the presence of drug-resistant seizures. And we define that as seizures that fail to come under control with 2 appropriate drugs at appropriate doses. Since this talk is about death and mortality, it's just maybe useful to briefly review how we look at mortality and how these things are measured. Sometimes it's a mortality rate, and that's the number of deaths that occur per year, and those can be looked at either per 100,000 of the population or per 1,000 people with epilepsy. It's a very common way of looking at the risk. When we talk about the rate of SUDEP among all people with epilepsy, the rate is about 1 per 1,000 person years, or 1 per 1,000 people with epilepsy per year. There's also standardized mortality ratios, and these compare the risk of death in the population of interest to the risk of death in the general population. So you might say the standardized mortality ratio is for people with epilepsy is 3.0, which means they're 3 times more likely to die. And then they also talk about case fatality rates, and we talk about those when we talk about status epilepticus. So for example, the fatality rate of status epilepticus might be 10%, meaning that 10% of people that present with status epilepticus die. So if we look at the causes of death in people with epilepsy, of course, the first point on this slide is the death can be completely unrelated to epilepsy. The death can be related to the cause of the epilepsy, and that's what we were talking about before, if it's degenerative disease or a brain tumor. Death can be related to the comorbidities of epilepsy, and a big thing here is suicide, because we know that depression, mood disorders, and anxiety are highly prevalent among people with epilepsy, and an unfortunate consequence of that is an increased rates of suicide among people with epilepsy. And then finally, deaths can be due to epilepsy itself, and those include direct consequence of a seizure, such as an accidental injury or a drowning, deaths related to status epilepticus, and deaths related to this phenomenon called sudden unexpected death in epilepsy. And I'm going to be talking predominantly about that today, otherwise known as SUDEP. Before I get to SUDEP, however, I'll say a little bit about some of the other causes because they're also important and I think relevant to your population. So when we consider epilepsy-related deaths, those are deaths due to the underlying cause of the seizure or as a direct consequence of a seizure or epilepsy, we recognize that 6.8 per 1,000 people with epilepsy per year or person years. So if you have 1,000 people with epilepsy living for 1 year, 6.8 of them will die within the first 2 years of an epilepsy-related cause. And after 2 years, if they've survived beyond 2 years, which kind of screens out most of the rapidly progressive causes of epilepsy that also increase mortality, the rate drops to 3.1 per 1,000 people with epilepsy per year. It's interesting when we consider the rates of accident and injury among people with epilepsy. Certainly you would believe that Canadians, people with epilepsy, would have an increased rate of injury, but in fact, Jose Tellez-Zenteno, a colleague of mine in Edmonton, did a review of the data that came in from Statistics Canada looking at people's self-report of epilepsy and their self-report of injury and accident, and actually found that there was no increased rate of injury in people with epilepsy. Now, in developing countries and around the world, drowning and burns are a significant cause of injury and death in people with epilepsy. There's some very interesting research out of China, more than one study, but the one I'm quoted in the bottom corner there by Ding, published in 2013, demonstrating the injuries suffered by people with epilepsy. And then you would suppose that people with epilepsy could be in an increased risk of traumatic brain injury because of falls related to epilepsy, but in fact, it hasn't been very well studied, but that has not been demonstrated. So actually, accident injury does not necessarily seem to be more common in people with epilepsy, but obviously it's potentially preventable when it's due to seizures, and so it's something to be considered. Status epilepticus is a potential cause of death in people with epilepsy. Cohort studies report a 10 to 30% case fatality rate. The majority of the fatalities related to status epilepticus, and that's SE on this slide, are actually related to acute symptomatic causes of status epilepticus. So not status epilepticus that occurs in people who already have epilepsy, but actually status epilepticus due to things like an acute infection like meningitis, an acute stroke, or an acute hypoxic brain damage following some acquired brain injury. Older age is also a risk factor for death due to status epilepticus. And in fact, death due to status epilepticus is extraordinarily rare in children. I realize you're not treating children in your population necessarily, but certainly my practice is in kids, and it's very rare to have death related to status epilepticus. It's also good to know that having had a history of status epilepticus does not increase the long-term risk of death. So life, if you survive status, and most people will, life expectancy is not shortened because of having had an event of status. I already mentioned the risk of suicide in epilepsy, and in fact, this is a quite significant problem. There's some nice articles on this. The references are in the bottom right-hand corner of the slide, but we do know that there are high rates of mood disorders and anxiety, and that anticonvulsants, furthermore, can actually exacerbate mood disorders and anxiety in susceptible individuals with epilepsy. And PWE stands for people with epilepsy. And so there's a variety of studies with a broad range of standardized mortality ratios, but the median standardized mortality ratio for suicide for people with epilepsy is 3.0, meaning they're 3 times more likely to suffer a suicide than people without epilepsy. And I think this is a particularly important concern for the prison population. And then among those causes of death related to epilepsy is this phenomenon called sudden unexpected death in epilepsy. And this is really the main topic of my time with you today. And so what I've put on this slide is the definition of sudden unexpected death in epilepsy. We call it SUDEP for short, SUDEP, and you'll see that on other slides going forward. And what SUDEP is a sudden death in a person with epilepsy when no cause of death can be found. So theoretically, you need to meet these 8 criteria, but it's really just a category of death. It's not a cause, because these deaths rarely find a cause. So the person to meet criteria for this obviously needs to have epilepsy, and we talked about that at the beginning of the talk. Epilepsy is defined as recurrent unprovoked seizures. The death needs to occur unexpectedly while the person was in a reasonable state of health, and suddenly, although it becomes a bit of a categorizing issue around if a person essentially dies and then is resuscitating, whether you call that a SUDEP or not. And so we have different ways of dealing with that, calling these cases probable, possible, near SUDEP, fatal near SUDEP, just different terms for when we do research. The death does not have to be witnessed, and it doesn't have to follow a seizure. Most often occurs following a seizure, or there is evidence that a seizure occurred. In fact, we are aware of quite a few cases where there was no evidence that a seizure had occurred, but the death happened nonetheless. And then point 7 is that the death can't be a consequence of status epilepticus, drowning, or trauma. And lastly, to meet full criteria for SUDEP, a postmortem examination, also known as an autopsy, does not demonstrate a cause of death. And when we're doing research about SUDEP, we also study cases in which autopsy are not done, because we recognize that autopsies are not often completed in people with epilepsy, and the reasons for that are complicated, but something that we're trying to work to improve. The circumstances of death in SUDEP are quite stereotyped, meaning that there's very strong similarities around the death circumstances from case to case. Individuals are very often found dead in bed in the morning in the prone position, so the face down position. That's quite a consistent finding. Only about 20% of these deaths are witnessed in the adult population, much more frequently witnessed in children. Of those witnessed cases, somewhere between half to almost all of the cases, depending on the study, have evidence of a convulsive seizure that happened immediately preceding death. And as we get talking, you'll see that the presence of a convulsive seizure before death seems to be important in how we think about SUDEP. So the incidence of SUDEP is listed there as between 1 to 2 per 1,000 patient years in population-based studies. So in some communities, people have been able to observe for SUDEP throughout the community using administrative, provincial, and state databases. And what they found that for 1,000 people living with epilepsy for a year, the average of 1 will die of SUDEP each year. It's much, much more common in people with refractory epilepsy, drug-resistant epilepsy, seizures that aren't controlled by medication, or those being evaluated for epilepsy surgery, which is a similar population, because usually it's the people for whom seizures are not well controlled with medication that are evaluated for surgeries. And so when researchers have looked at those populations, the rates can actually be up to 10 times higher, so almost 10 per 1,000 people with epilepsy per year, or 1 in 100. There was a nice study that looked at people who developed epilepsy as a child and then followed them 40 years. And there was a 7% risk of SUDEP over that 40-year follow-up period. Most of those occurred during adulthood, but the common thing to the cohort was that their epilepsy had started in childhood. There's been some nice work looking at the risk factors for SUDEP, so comparing individuals who have died of SUDEP to people living with epilepsy who have not died. Quoted on this slide, the nice studies, and what they found was that frequent generalized tonic-clonic seizures, that's GTC, frequent generalized tonic-clonic seizures are the most strong risk factor for SUDEP. I've written polytherapy there and written a red line through it because that paper actually found polytherapy, or being treated with multiple anticonvulsants at once, to be a risk factor, but in fact they later disproved that, and I'll get to that in a moment. So the strongest risk factor was the frequent generalized tonic-clonic seizures, and then another very important risk factor was younger age of epilepsy onset, which may play into duration of epilepsy. So it may be that you get it younger, so then by the time they have a SUDEP, they've had the epilepsy longer, so their body has experienced more seizures. But younger age of epilepsy onset may also be related to the causes of epilepsy in young people as opposed to the causes in older people. So we can't really say for sure. But just to put it into perspective, if you look at the last couple lines on that slide, you'll see that if a person has 3 or more generalized tonic-clonic seizures per year, their risk of SUDEP is increased 12 times if their epilepsy started over the age of 16 years, higher if their epilepsy started under the age of 16 years. You know, we talk about frequent generalized tonic-clonic seizures, and some people might think that's like 1 a week or something, but this is just 3 or more a year. So really, you can call them frequent, or you might just say any generalized tonic-clonic seizures. And the more generalized tonic-clonic seizures a year, the more likely a SUDEP is to occur. So this is the paper here published in Epilepsy in 2012 that asked the question whether it was the generalized tonic-clonic seizure frequency or the drugs that was increasing SUDEP risk. And this is where they disproved that polytherapy, being treated with multiple drugs, was a risk for SUDEP. And the way they did that is, what they had failed to do in their first study is they had not controlled for number of seizures when looking at number of drugs. So obviously, if you have a patient with many seizures, they're more likely to be on multiple drugs because one drug alone is not controlling the seizures. So in this study, they adjusted for the number of generalized tonic-clonic seizures and found that, in fact, there is no increased risk of SUDEP associated with being on one drug, multiple drugs, or any specific drug. When they looked at all the drugs individually, there's no increased risk of SUDEP. And that's a very important message, because it would be a disservice to our patients if we imply to them that somehow taking the drugs that we're trying to use to treat their seizures was somehow increasing their risk. That would be incorrect, so we don't want to do that, obviously. Also, on the topic of the role of antiepileptic treatment or antiepileptic drugs, the role of reducing SUDEP risk by taking drugs for epilepsy, this is a very interesting study in which Philippe Rivelin combined 112 randomized trials of drugs. So when a drug company wants to bring a new drug to market, they need to prove that it's effective. And so the way they do that is they enroll patients in studies where they take their regular drugs, and then they either get the new drug added to their regime of regular drugs, or they get a placebo added to the regime of regular drugs. And they found in this study that the patients who received a placebo had a risk of SUDEP of 6.9 per 1,000 people with epilepsy per year, as opposed to the people who got the new add-on drug at the right dose, at an efficacious dose. Their rate of SUDEP was that of the rate of SUDEP of the general epilepsy population. So it actually appeared that the people with placebo had a higher rate of SUDEP, suggesting that taking drugs for epilepsy that are effective drugs reduces the risk of SUDEP. There's been a lot of work looking at risk factors, and so I've listed a few additional SUDEP risk factors that have been identified here. One of them is nocturnal seizures, so seizures that occur at night, and I'm going to touch on that in the next few slides. Further to that, having epilepsy for a longer duration. So it appears from some studies that male gender, learning disability, and learning disability are risk factors for SUDEP, although these are non-modifiable risk factors, so it's difficult to know what to do with that. And then finally, young adult age. So the key age for a SUDEP to be identified is between 20 and 40 years of age. Some of that, though, I need to say, is because autopsies performed in older people will almost always find a competing cause of death, making it more difficult for the pathologist to sign the case out as a SUDEP. So this is called sudden unexpected death in epilepsy, but we are getting closer to being able to expect this unexpected death. We know who's at highest risk. We know that at highest risk of SUDEP are adults, those with early onset epilepsy, and those with refractory or drug-resistant generalized tonic-clonic seizures. And that means that when we think about reducing risk of SUDEP, seizure reduction, particularly generalized tonic-clonic seizure reduction, is our most important treatment goal. And so the keys to SUDEP prevention that we share not just with healthcare providers, but with people living with epilepsy is that the first step should be seizure reduction. This will be supported by adherence to anticonvulsant medications as prescribed, identifying and avoiding triggers for seizures, keeping their regular medical follow-up, and then importantly, referral to a comprehensive epilepsy center when seizures are drug resistant. And it's very, very important because of the possibility for surgical treatment of epilepsy. Once medications are not working for epilepsy, people should be referred for surgical evaluation. Surgery can potentially cure individuals of epilepsy, dramatically reducing their risk not just of mortality, but of all sorts of other comorbidities associated with epilepsy. With regards to point number 5, I'll touch on that a little bit more at the very end of my presentation and make you aware of some new guidelines from the province of Ontario on treating people with epilepsy. So I mentioned that nocturnal seizures are a risk for SUDEP. This is an interesting finding. First of all, we know that the majority of SUDEP occur at night, occur in the sleep environment. Since most are unwitnessed, we don't know if people were sleeping when they died, but we do know that they're in a sleep environment, be it a bed or their regular sleep environment, and they're typically unwitnessed, so we're not sure exactly what happened. There is a study, the reference there at the bottom, which compared people who died of SUDEP to people who did not die of SUDEP and found that at night they had an over 2 times increased risk of SUDEP. What would be some of the reasons why nighttime or sleep enhances SUDEP risk? One of them might be that people are more likely to be alone and unsupervised at night. Another could be something about the environment, being in bed, being with pillows and other things of that kind. We know that the brain is more likely to seize from the sleep state. So being asleep or sleepy makes it more likely for a seizure to happen. So that could be a factor. And there are other physiologic factors such as the autonomic changes that happen in the body when people are sleeping, changes in our blood pressure and in heart rate, and whether those somehow put people at risk. Finally, there's this issue of whether the fact that they're alone and they are maybe not supported in the post-seizure period or the post-ictal period, whether that increases risk. And so there's been some discussion around whether nocturnal supervision could be protective for SUDEP. And there are 2 studies that found a role for nocturnal supervision in SUDEP. One study was conducted looking at SUDEP among individuals who lived in a residential school for people with epilepsy. So these were young adults who lived in a residential facility. And all the SUDEPs that happened in that population actually occurred when the students were home for home visits. So none of them occurred in the school setting. And the thing about the school setting that they felt was protective was the fact that they had frequent nocturnal checks and a nocturnal surveillance system in place for the residents. The other study demonstrated that people who either shared a room with someone, so didn't sleep alone in a room, or who had some sort of monitoring overnight were less likely to have a SUDEP. So these 2 studies suggest that nocturnal supervision may be protective for SUDEP, and that may be relevant to your population in prisons. Another relevant study is this study called the Mortality study, which looks at mortality occurring in epilepsy monitoring units, hence the MORT for mortality and EMU for epilepsy monitoring unit study. What they did here is they actually collected the data on cases of SUDEP that occurred while patients were admitted to epilepsy monitoring units. So these are usually hospital-based units where people are admitted for us to get a better idea of what's happening with their epilepsy. They're often weaned down off their anticonvulsants, hooked up to EEG, and then we wait for seizures to occur so that we can learn more about their seizures. Now, we run an epilepsy monitoring unit at the Hospital for Sick Children, and ours is very, very heavily monitored. First of all, we require that a parent stay in the room the entire time, and there's nursing staff 24 hours a day, and there's video monitors and EEG monitors into the nursing station. But some epilepsy monitoring units around the world don't have quite as much surveillance, and for that reason, I think deaths have occurred at epilepsy monitoring units. So they collected from around the world 29 cases of cardiorespiratory arrest that occurred in epilepsy monitoring units. 16 of those turned out to be SUDEP, of which 11 they had monitoring information, and 9 were near SUDEPs, which means that they died but were resuscitated, 5 of which they had monitoring data on. What they found for the SUDEP cases and the near SUDEP cases was that they all followed a generalized tonic-clonic seizure, and they all had this interesting EEG pattern, which is that immediately following the seizure, there was like this profound flattening of the brain waves. So the EEG demonstrates a very, very reduced amplitude of brainwave activity. And one of the interesting findings was that all the near SUDEPs that were successfully resuscitated had CPR started within 3 minutes, in contrast to the SUDEPs where people were not resuscitated successfully. The CPR usually took at least 10 minutes to get started. So that also suggests that there may be some role for an immediate intervention at the time of the fatal event to avoid death. Usually when I start talking about SUDEP, people say, well, what's going on here? What is actually the mechanism of death in SUDEP? And are there some biomarkers that can identify those at highest risk? So I'm just going to touch on those issues briefly. With regards to biomarkers, the idea is, can we find something that differentiates the 999 people living with epilepsy for a year who will not die from that one who's at highest risk? Because if we're talking about interventions like increasing nocturnal surveillance, is that something we're going to do for everybody with epilepsy, or do we want to use that type of relatively potentially invasive procedure on people who are only at the highest risk? And so there's been work looking for different biomarkers. There's some genetic work, some physiologic work, both in neurophysiology and cardiorespiratory physiology. So I'll touch on those briefly. This is just a schematic outlining the theoretical considerations for mechanisms of death in SUDEP. So if you look at the purple box here, chronic epilepsy, everybody who has a SUDEP starts out having epilepsy, and then something happens that allows for a respiratory or cardiac arrest, and then the death occurs. Now, there are factors that are intrinsic, going up, related to the person's body that could be contributing to the death cascade. And then there are extrinsic factors, things that are happening in their environment. So starting with the intrinsic factors, it's possible that chronic epilepsy, over time, more and more seizures, and we already heard that the frequency of seizures is a risk factor and longer duration of epilepsy is a risk factor. So it's possible that chronic epilepsy causes changes in heart function structure, brain function structure, or some autonomic dysfunction. It's also possible that some people with epilepsy have genetic factors that predispose them to sudden death, or genetic factors that predispose them to both epilepsy and sudden death. And it's also possible that there's something about that one last seizure that precipitates the death. And then when we think about extrinsic factors, we recognize that it could be something we're doing with not the prescribing of drugs, but perhaps the changing of anticonvulsant drugs, or we know that for anticonvulsant adherence is a risk, or something about the sleep environment. And with sleep environment, we think a lot about sudden infant death syndrome and recognizing that when we started putting babies to sleep on their back, the risks of sudden infant death syndrome have reduced dramatically. And other things about the sleep environment, like not using too much bedding, and whether these things play into the risk of SUDEP, we're not really clear. So thinking about some of the potential genetic predisposing factors, we recognize that long QT syndrome, which is a very well-recognized cause of fatal ventricular arrhythmias and sudden unexplained death in young people, is caused by mutations in 10 or more genes, including 8 genes for ion channels. And we also know that epilepsy can be caused by mutations in ion channels. So in fact, it's quite enticing to wonder whether there could be a single ion channel mutation that underlies both epilepsy and cardiac arrhythmias. And in fact, this was demonstrated in animal models. Jeff Nobles and those that work with him in his lab at Baylor University in Texas have demonstrated that there is a mutation that predisposes rodents to both epilepsy and sudden death, and that's a putassium mutation that we do find in some people with epilepsy. And so it's an interesting finding, and certainly when we see people with this mutation, we recognize they are likely at increased risk of both sudden death and epilepsy. We also wonder about whether certain features of people's body's reaction to a seizure may put them at more risk of SUDEP. So we know that asystole, or your heart stopping, is very rare in epilepsy. Only 0.4% of adults have their heart stop during a seizure, but changes in heart rate variability can actually be much more common, and abnormal heart rate variability is a risk for sudden death in the general population. Further to that, apnea, or stopping breathing for 10 or more seconds during a seizure, can occur in up to 55% of patients in an epilepsy monitoring unit. And actually, hypoxemia or low blood oxygen levels can occur in up to 35%, even when they don't have a convulsive or shaking seizure. So there's a lot of body changes that occur during a seizure, but we don't know whether those predisposed to SUDEP or not. Finally, there's that EEG pattern that I made mention of earlier, where it was demonstrated that of all the SUDEP cases that occurred in the epilepsy monitoring unit when they had an EEG running, there was that EEG suppression or flattening of the brainwaves that occurred in all of the epilepsy cases that died in the EMU. And here's further evidence that that EEG suppression pattern could be important. They looked in this study on this slide, they looked at the EEGs, they looked back at the EEGs of people who later they know had died of SUDEP, and they actually found that half of the seizures in patients who later died of SUDEP had that EEG suppression pattern even when they didn't die. So whether that could be a marker of people who are at risk of SUDEP is something that quite a few centers, including our own, are trying to understand. I think that the bottom line when people ask me for a cause of SUDEP and what I think the mechanism is for sure it's going to be not one cause. So it's going to be multifactorial, in some cases due to one thing and in some cases due to another. And then also I think an attractive hypothesis is of a multi-hit model, because we need to consider there are people who have many, many, many seizures, and something different happens on that one day, and that one day, that time, they die. It's coming together at that time. So I've given one example there. A person with epilepsy who has frequent generalized tonic-clonic seizures, but on that day has a more profound hypoxemia associated with their seizure, and then that somehow predisposes them to have that EEG flattening, which then predisposes to death. So at this time, we really don't have a perfect biomarker for SUDEP, and risk reduction really remains the most important goal. I just wanted to finish up by giving some thoughts from some of the reading I've been doing around how we can optimize seizure safety in prisons and reduce SUDEP risk. So some of the recommendations that I'm aware of come from my readings and not from my own personal experience on ways to keep people with epilepsy safe within the prison population are listed here. That includes avoiding single-cell occupancy so that a roommate or cellmate is available to alert if a person in prison has a seizure. And of course, if they are sharing a bunk bed situation, being on the lower bunk obviously would reduce injury risk. And if they're not sharing a cell, then some sort of regular monitoring when people with epilepsy are alone. Also, encouraging prisoners to disclose their epilepsy to the correctional staff and the cellmates, so that those people who are around them every day are aware of the risk that they're at of having a seizure. And of course, training for correctional staff and prisoners regarding seizure safety and emergency care. With regards to specifically reducing SUDEP risk in prisons, really the focus is on reducing seizure frequency. And the way to do that is, first off, to really know about the prisoner's epilepsy. We really need to understand the condition. And that includes a complete nursing assessment at the time that they're admitted to the facility. And that has to include getting their complete medical history to the best of our abilities. Just like we have in my pediatric practice for children who are attending school, there needs to be a clear seizure management plan for any prisoner with epilepsy, including regular review of that plan, both with the staff, the healthcare staff, the correctional staff, and with the prisoner as well. Optimizing adherence to epilepsy treatment is very important, and any way that can be achieved would be beneficial. And minimizing exposure to seizure triggers. The biggest seizure trigger for most individuals with epilepsy is sleep deprivation, but other physiological stressors and even emotional stressors can trigger seizures as well. Following a seizure, particularly a convulsive seizure, it's warranted to have a medical review, preferably by a physician or an advanced practice nurse, of the patient's or the prisoner's epilepsy management. And any patient with epilepsy who has drug-resistant seizures, defined as seizures that don't come under control with 2 medications, any of those people should be referred to an epilepsy center. At the very least to a general neurologist, at the best to an epilepsy specialist. And in fact, on that note, I'll draw your attention to this document published by Critical Care Services Ontario just this year in January 2015. And these are provincial guidelines from the province of Ontario for the management of epilepsy in adults and children. But if you go to this website and you go to the toolbox, you will see this document listed there. And I think it's worth reading if you're caring for people with epilepsy. Finally, I wanted to draw your attention to some documents that SUDEP Aware has made available to any health practitioners or people with epilepsy. And these are available for download on the website. And the website is www.sudepaware.org. And what we have are informational materials for people living with epilepsy, for people bereaved by epilepsy, for young people living with epilepsy, and for healthcare providers. It's a very high-level basic information about SUDEP and how to reduce risk and how to stay informed.